Okay, during the second hour, what we're planning on doing is really talking to you more about what your work would be at the community level, and how do you get your coalition started, the different task forces that you may want to establish, how do you get people to the table, making sure that you've got a whole group formed. And we're going to cover a little bit about the history and then kind of how we would provide resources to you along the way. So as we mentioned earlier, we began in the KC metro area with our own task force. This was our own community task force that we put together. We then moved to Topeka, did the same thing there, created a task force among the hospitals and EMS and everybody. Karen and I did a number of trainings over there, and then we got them to the point where we said, all right, now you guys need to start doing your own training. We can provide resources to you. You can use our videos if you want to use those, but you need to be able to form the leadership group that you're going to be able to have available to you and begin to implement your own process that you're going to do. And then you're going to decide at some point that you're ready to launch and go live. So this hour, we're going to take kind of the elements of that and say, what do you need to do here in Republic County to make sure that you can get this done, hopefully within the next 6 to 9 months or whatever your goal is to be able to implement. So it was really at the behest of the national pulse paradigm that we moved from basically community coalitions to a statewide coalition. They were not interested in having 15 different community coalitions in Kansas and Missouri. They wanted a by-state or a state-by-state initiative so that we would then have kind of an obligation and understanding that the forum would be recognized within all 105 counties in Kansas and that kind of thing. So we said yes, we would do that, but we knew that the way that was going to happen is through the efforts that we were going to establish at the local level. So what we did though, however, in providing, and this is just available to you as a resource, we put together a bi-state leadership team that represents all the different elements that are going to be represented at the local level. So you have a corresponding, not necessarily an expert, but certainly a liaison at the state level. So if your local EMS person has a question or your local hospital person has a question, you've got somebody to call at the state level and we can put you in touch with them. So as we mentioned earlier, Susan's kind of our long-term care expert. We've got educators, nurse educators. Karen's our physician champion. She's already had at least 1 or 2 calls with physicians in local area physicians that have questions and comments. I did a follow-up session with the physicians in Salina who had some questions. So we're ready to do that at your request so that it helps you then facilitate the work that you're doing at the local level. So the folks you need to make sure that are at your table when you get started are obviously the hospitals, long-term care, EMS, and then we also have some representation at the State Hospital Association. You may want to include your alliance, if you have any alliances out here, to make sure that this is, if you've got hospital providers for people outside of the area. I know some of you may have patients that are going to Salina Regional because you're a critical access area and you need to have a tertiary institution. Then obviously, and Kathy Pike is the person in Salina. We can put you in touch with them. They've already adopted the program. They're moving forward. We don't really have any involvement with folks in Nebraska. I don't know where else you go, probably east to Manhattan, maybe. I don't know how far beyond the Salina area you go in terms of the patients that you're serving. We also are working with the long-term care associations, and we'll actually be doing some training with their state associations in the course of the next year. And then hospice and home health. We've been working with them for a number of years. I'm a hospice person from decades ago, so we've got a pretty good inroad with them. We're planning on doing some additional training with them to kind of update them on things. So your state association should be able to provide you some good information. We actually have a medical society that actually acts as the convener in Sedgwick County. So if you have a medical society, county medical society, that's good, but in many cases it may be more just your physician practices. We are also working with the Bar Association. Some of you may be aware that there's an Attorney General's opinion on TPOPP that's been issued, and we're working with the healthcare attorneys in the state of Kansas to make sure that all the hospitals understand the Attorney General's opinion and interpreting it correctly. And then we also received some support from foundations and have had some other foundations, not in the state of Kansas, that have provided support beyond the Kansas Health Foundation. This is just a quick snapshot, I think, of the resources that you have in terms of the leadership. We've kind of did a description of the paradigm on one side, and then identified the 9 leaders that we have that are working with us right now in terms of the leadership team. Karin mentioned Angela Farah, who is she's not with MedAct, she's with Johnson County, she is with Johnson County MedAct, and she actually serves in the National Pulse Paradigm EMS team in terms of implementing integrating EMS into the team process nationally. So the bi-state leadership scope is really to make sure that we have centralized operations, that everybody's kind of operating and singing from the same hymnal, hopefully. We're coordinating our information and our data collection. We are actually have an institutional profile that you do online that gives us information, gives you information, and then we can hook you up with other people in your community that have also filled out an institutional profile. What we're trying to do is make sure that you guys know about each other in your own communities, and we're able to share that information so you know who the other folks are in the community that are interested in participating in the the TPOPP initiative. And then we have constant routine communication with the National Pulse Office. I serve on a task force nationally that deals with spiritual issues, so how the different churches and faith communities look at Pulse Paradigm, and some look on it more favorably than others, and we try to address their concerns. So again, even if you've got local churches, ministries that are out there that want to participate, if they need information on how does my church look at this, and does my church support these kinds of things, we can get you that information. And faith partners can be a very good way of making sure that you're integrating, obviously, the work into the community networks.
And when you get ready for community education, they're a wonderful avenue into community,
to gathering, for you to ask them to host sessions and that kind of stuff. We've done a number of presentations at Lenten series and those kind of things they're great ways to really engage the community and educational. And then we also do a lot in terms of sharing best practices and lessons learned. Karin's particular emphasis and focus on using the right language, having the right skill set, asking the right questions, and training providers how to engage in these conversations is very important in terms of the success and how well it's adopted in your community. We also serve as a distribution center. We have a TPOPP website that's integrated into the center's website, and then you can actually, through registering, get the information, download the information, and then that's the way that you'll actually get communication and notice from us when there's a webinar or available information in terms of archive data that you can pull down and watch on your own and that kind of stuff. So Matthew will be coordinating that. Educational form?
No, well, this how to get that.
How to get forms.
Yeah, the educational form I believe that you have that actually has the TPOPP form itself is you can also order these from the website so that you have them. If you're ready to launch and implement, you can actually get the form that doesn't have the education block on top of the signature form. But you can only get that form with no education block on it if you're ready to implement, and then we'll go ahead and let you order the forms so that you can have them in your community. But we ask that you not do that until you're ready to go, until your community's ready to go.
Yeah. How I use this form, so we've heard about area centers on aging handing out forms. No, it's a physician order that should only be coming out of a physician's files in their office or at the hospital. If folks want to use the form as an educational tool, the nice thing about this one is that it says for educational purposes only, and you can see it's purposeful that it says if you want the real form, go to TPOPP. So the signatures, there's no way that this can be mistaken for an actual, TPOPP order. I use this one when I'm having a serious illness conversation with a patient and family, and I say, is this something you would want to have in place, at home or wherever? And it's not unusual for the patient to go, oh, let me see that. And they want to look at it, they want to read it, they want to take it home and talk with their loved ones about what it looks like. But we don't let the real live physician, or it's a physician order set, out you know? A couple reasons. A, it's a physician order. B, if they think they're completing it and signing it and it's not signed by the physician in a discussion with the physician, it's not an actionable form, and it should not be respected if it does not have a physician's signature on it. So it's just a couple between the lines that are important about these types of documents and how we use them on the ground.
And we actually, this is a companion piece to our Caring Conversations. The center has a Caring Conversations Advanced Care Planning resources, a number of them. This actually goes inside of a little document that's called the Caring Conversations Continued, because it is obviously for those that are ready to advance in their discussion about their advanced care planning. It's not just their naming of the agent. It's not just their discussion about their goals and preferences. This is actually about what I talked to my doctor.
The serious illness piece.
The serious illness piece. So in here, in this document, that's the Caring Conversations Continued, it says if you've already filled out your advanced care planning documents, you've already had this discussion, and you're interested in talking more to your doctor about what you would and would not want because of the fact that you're already facing a serious illness, take this form in to your doctor and sit down and talk to your doctor about it. So as Karen said, the conversation can be initiated by the patient, but the form is not initiated in terms of its signature, the execution of the form, okay? Okay, and this, the next slide is really just basically kind of an image of the way that the system works. We have the PULSE, the National PULSE Paradigms at the top, the Kansas-Missouri TPOPP Coalition, which is the leadership team that we've assembled and working with the different communities is kind of in the middle. And then we have our community task forces, and that's what you guys are thinking about creating today. It's why it's very important. And so this is really kind of a grounds up. We work based on the roots of the organization actually being in the communities. We're alerted to the issues that you consider to be important. We get out there and try to do the education, provide you the resources, the tools, and those kind of things that you need to develop your policies and procedures and have your meetings, your community meetings and things like that. So we serve as a resource to you to make this effective and be able to be adopted in your community and implemented effectively. Right now we have about 14 active local coalitions, some more active than others. We have about a dozen other communities. This is both in Kansas and Missouri both. We have about a dozen other communities that are in your guys' situation where you've expressed an interest. You want to start talking about it, and you need to get your folks together to be able to see whether this is something you really want to do in the next few months. This is research that was done in California, and I'm going to let Karen talk about it because I think it really kind of reinforces the importance of basically, a law is important to get things started, but the community coalitions are really what makes this thing work.
So California I was saying in the other talk that I gave today, California has a law around California Pulse is what it's called. And then they also had a large grant, a great funding mechanism machine that helps to drive ongoing financial support. So, they're very fortunate. They work really hard and they've been able to move, really quickly in terms of how fast they've developed. So you'll notice on the national map that California is already dark pink. And, that is a testament to their hard work, the funding that they've had, and also just the concepts around that. And the law, At the end of the day, though, it turns out that even if you have big grants and even if you have a law, it has to come from the bottom up, And the reason why is that at the core of this is changing how we practice, how we practice with patients and families, and how we work together as a community of providers. And you can't legislate that. You can make a checkbox on a form, and what you end up with is people getting asked if they have an advance directive, by an admissions clerk at the hospital. It doesn't actually change, right? Turns into a checkbox. We don't want checkboxes. And so the grassroots idea of this is a better way to do things, and this will help move us forward in providing better care. This will empower our patients and families to be more informed, but also to be able to say what's important to them. That has to come from relationships, doctor-patient relations, provider-patient relationships, and then teamwork amongst, each other, you know, between the hospitals and long-term care, EMS, hospice. You know, what we're coming to realize is that when we don't have a good safety net, community safety net, for when someone's out of the hospital, we haven't built that safety net of providers, communication, and shared understanding practices and procedures. The safety net breaks, and then what happens? 911 hospital. We end up back in the hospital. And so there are a lot of drivers to how do we help people stay out of the hospital, you know, and how does medical care get looked at as a whole, you know, moving away from fee-for-service to bundled payments. All of these are drivers of all of us got to work together to provide care for that patient over a period of time across time and space. So I think we're hitting a tipping point where some of these drivers are actually pushing us to provide better care. And there's more incentives to do that now, really, than ever. So they did a study in California where they were looking at areas that had community coalitions develop, formalized community coalitions, compared to not. California is a huge state, and so they were able to draw those lines and see. And in the models, in the places where they had community coalitions set up, people were more likely to have forms. It was more likely to be integrated into the actual medical culture and practice. So, there you go.
Okay, this is a snapshot of where we are right now in the state of Kansas. You'll notice that there's a huge area in the Northwest, 16 counties, that's kind of being coordinated by the hospice services of I think they're called hospice services in out of Phillipsburg. And so Joe Barnes, the physician champion there, has been working with us along with Sandy Coleman in terms of helping coordinate some of the communities out there. You'll notice, I think you guys are located there. Belleville is listed as one of the developing or interested communities, so hopefully we'll be able to change you to a star pretty soon as you guys get further down the path to active. We have the south central part of the state has got a number of active communities with Newton, and I think Kingman is probably listed there, Wichita, El Dorado, that area. And then obviously probably our most mature city in the whole state is in Topeka, but they've been at it since 2010. And then some of the areas around there. So Pittsburgh is coming on board mainly because of the work that's been going on in Springfield, Joplin area. They've got some very, very active work going on in the southern part of Missouri. So we've seen a lot of good activity down there. So obviously there's still some areas of the state that we haven't gotten going yet, but we're hoping to be able to move in the right direction there. So if you have, again, this was a kind of a slide sometimes that we've suggested to communities that they use when they gather their community to show that it's not just us, and there's lots of other people around us that are engaged in this kind of thing, and we're not alone, and a way for us to be able to kind of say, okay, we're all going to get together on this and move forward in the state.
I have a question for you. Since we have folks here from Concordia, which is even in a different county, but they've been indicated.
We could. I mean, it depends on how what we've done is we've let you just tell us if you want to have a separate coalition or not. We've kind of gone back to a few people and said, really, you need a separate coalition? I mean, like, you're 15 miles from Wichita. Why do you need a separate coalition? But they wanted one, and they wanted to create one, and they wanted their own community, and they wanted their own nursing homes, and they had their own EMS. And we said, okay, fine, you can have your own coalition. That's fine with us. But please make sure that if your tertiary hospital is the one that you're working with, that you're not leaving that hospital out of your coalition, because Wesley or St. Francis or Via Christi need to be part of your coalition if in fact you're transferring those patients back and forth. So, and I don't know that in this part of the state that you'd want to necessarily have folks like Kathy or whatever from Salina be on every call or every meeting, but keep in mind that your sister communities around the area need to be part of your coalition if in fact you're not going to be a standalone. But for those of you that are there's not a lot of staff and you need to kind of create a nucleus of folks that all agree that this is what we're going to do, we're fine with you listing it, and we'll put you on the map and say that you're covered and you're ready to go.
Quick question.
Sure.
You mentioned hospice incorporated. Did they?
Hospice Services, yes, incorporated.
Out of 16 counties, is there a point of contact?
Yes, Sandy Coleman.
Sandy Coleman?
Yeah, Coleman, Kuhlman. What I would have you do, if you're interested in any of the communities, is just get a hold of Matthew. And then we've got, he's in the back, and the material you've got handed out has his name on it. Just get a hold of him and say, I'm interested in contacting one of these other communities, and then we can put you in touch with them. And then the institutional profiles that we're going to ask each of you to fill out would allow us to then be able to share your information with other folks around the state who may have a question for you. So that's the reason for the institutional profiles and REDCap in terms of gathering the data. But you can do that.
Profile. Did we get ours completed, our hospital?
Yes.
Okay.
Okay, so the institutional profiles are what this is part of your community coalition. When you build your community coalition, you will identify for us who it is. Somebody goes in representing your coalition, the leadership of your group goes in and creates the institutional profile that gets things started. And then you identify in there other institutions that are interested in participating with you or that you need. And then those people are invited to participate and create their own institutional profile. And then you identify each other, and that's how we know that your community coalition is forming and you're getting the right people and the right partners in the room together. And then if we see over time that your community coalition has been meeting for a year and you've got lots of people but you have no EMS and the EMS are not involved, we're going to call and say, you know, it's important for you to have EMS involved in your community coalition. We don't see them. And it's like, oh, well, that's so-and-so and she's the, you know, she's the DON at the nursing home. And so we didn't bother to list EMS because she's also, or her husband is the, you know, and we understand that in small communities. That may be that it may be somebody's spouse and they're already getting notices, so they don't need another set of notices. So we'll just fill that information in. But what we need to see is that the coalition is forming and that there's good representation from all the different segments of the community. So what we're going to ask you to do, and this is kind of repeating what I just said, is to assess your own institutional readiness to do this and the coalition's readiness. That's really the work of the leadership group. And then the leadership is saying, okay, are our hospital policies done? Has Med Exec Committee met? Have they approved this? Do we know that we can tell, you know, the folks in the community that the hospital's ready? I will mention, and I don't think we have this slide in our deck anymore. Kansas Department of Health and Environment has made it really, really clear to us, in order for TPOPP to work in any community, the hospital in that community has to have adopted policies related to what they're going to do if a TPOPP form shows up. Okay? They have to have it in writing what they're going to do if the TPOPP form is there. If that doesn't exist, then KDHE is saying your hospital is really not ready to receive forms yet. Okay? That was
So
the
then
only
look at-
stipulation they put on us.
So what's important to know is that usually hospitals have policy around how do they handle out-of-hospital DNR orders. So it's a matter of looking into and saying, okay, how does this need to be adapted, you know, for the purpose of TPOPP.
So current policies may just need to be modified.
Right.
As opposed to a whole
Brand new.
policy, depending on what's in place already.
We'll talk
So if
about
you have a policy already that says something, then what some people have is just put a comma right after the DNR, and it says TPOPP right after that, or transportable physician orders. It could be that simple depending on how your policies are. But that'll be the third hour, and we'll talk, the two of them will talk more about it. So back to the coalition. Leadership is absolutely essential. This is one of the hard lessons we learned from Topeka. We thought we had, and we did at the time, we had a physician champion within one of the hospitals. And within 2 months of going live, she left. She took a different position. And the implementation within that hospital just basically shut down. And there was really no physician really championing, even though they had their policies done, their Med Exec Committee had met and everything else, they didn't have a physician who was really shepherding the process and being the champion internally. That can happen in a home health agency if you lose leadership there. It can happen in a hospice program. It can happen in any of your EMS person changes jobs, and that's the person who really thought this was a grand idea. And I really can't tell you how important it is for the individual leadership within community coalitions that really spark the enthusiasm and the passion to make this work. And it's absolutely essential. Your local leadership is absolutely essential. So you really need that person to step up and say, yes, I'm going to take this on. And even if it's for a short period of time, 6 months, I'll help with the formation, but after we get started, I can't continue to commit to do this. You really need somebody to get excited about that and be able to say, these are the steps we got to go through, guys. Kansas City sent us this list and we got 5 things, and our institutional profile is asking us questions and we don't have answers. And that's really what we're hoping the institutional profile will do for you, is that if you can't answer a question, it just means you haven't answered the question yet. That's all it means to us.
And it's okay.
It's okay, because we know the formation takes time. But it's important to answer the question. And at some point, we're going to call you and say, if it's 2 years down the road and you haven't answered the question, like, where are you? What's going on? What can we do to help? Because that's really all this isn't a test. This is just, what can we do to help facilitate the process moving forward? So interdisciplinary, skilled nursing facilities, assisted living. Some of you that may have continuous care retirement communities, I got to tell you, in some of the areas in Kansas City, there's been big stop signs put up for us for assisted living and independent living. They know how to do it in the long-term care setting, but they have no policies in place in terms of what are they going to do if somebody in assisted living falls and we need to call 911 and they don't want to be resuscitated. They had no things in place. And so they said, you're fine to go with our nursing home, but we're not ready on assisted living and we're not ready on independent living. So those are considerations that institution may have to resolve for themselves in terms of, are we going to implement or not? One of them actually set down, they're not implementing at all because they feel like they need to have it all through their whole continuous care retirement. Making sure that you've got a good balance among your professionals in terms of disciplines. Social work is important. Community leaders, sometimes maybe your community volunteer, who's maybe the hospice volunteer from 30 years ago, maybe the best person to lead your community coalition. So you need to be thinking about how it is that you draw on those leadership to make sure it works. So physician champion, and Karin can speak to this in terms of both the statewide and the institution. Time is really obviously short for them. So utilizing them well, making sure that they're your person, your go-to person, but also making sure that they're not being asked to perform a lot of administrative, really important minutia details that need to be done. Make sure that you're utilizing their resources and their skills well too. So the way to get started obviously is contact us. You've already done that, but for any other community coalition, if you guys are going to start your own in Concordia, that's the way you would do it. Register with us. That'll get you access into the resource kit, and then begin to communicate with us about what it is you want to do. And then we'll be following up with you about checking with your readiness, if you have the right people, you feel like you're making progress, and kind of what the steps are. There's a whole bunch of different steps to suggestions in terms of protocols and procedures and policies and things like that for the different nursing homes and home health agencies and that. Okay, Karin?
So I'll take just a little bit of a pause to check in. When you guys hear all of this, what questions come to your mind? Are there thoughts, excited, scared? What are your thoughts when you hear all this?
I think it's great to, on several levels. Number one, just to make sure those things are in place, because I have been that ER nurse where that person comes in. I know they're supposed to be, and I thought they were, and where's the paper, and where do we find somebody around to the clinic, or let me get the paper from the nursing home, and, as well as just having the conversations. And I like that instead of making the decision end of life, where they have to make that decision. This way, you're living with whatever serious illness it is, and that kind of takes the pressure off, and then you can start talking about it, and then being able to carry it through. But now being able to have some good systems in place to where we can then work with EMS and roads and us. And so I'm excited that there's hopefully some of those tools that we can use to implement it quicker and get the docs on board with it.
And the development of the tools, if you don't see something in there that you need, just give us a call and say, would you care if we changed this and did this with it? I mean, this isn't, there's nothing in there accept the document. That's really sacred in terms of changing. We don't care that, I mean, this isn't copyrighted stuff in terms of the caring conversation stuff is copyrighted, but the rest of this is really for you guys to be able to use in a way that makes sense to you. So if you want to change some of the stuff and drop some of it, you know, it's too focused on big hospitals, we want to make it more focused on smaller communities, that's fine with us.
We probably just ask if you change it, send it.
Send it to us so we see it.
Know, you know, so we have a library of what people are using, you know, and how you want to change it. Because we might be able to say, I gotta get, okay, you want to talk more about X? I'm actually aware of a reference, you know, or where to go along those lines. So, okay, well, great. Are there other thoughts or comments?
I love that it opens the door to the conversations that aren't being had.
Yeah.
Mm-hmm.
So often we get these people on hospice and they've not had any segue to the fact that they're have an illness that is going to lead to death, and they're shocked by the time we get them. And if they can have time to prepare and live and make some decisions about how they're going to spend that last time that they might have, it's huge.
Yeah.
The other
The comment is about, for those on the online, the comment was about the importance of being able to have this conversation earlier, and the benefit that this kind of a community effort would facilitate having those conversations in the community.
The other thing that's nice about the use of the form and having that conversation, or having that conversation and using the form, it's not regulated by the Medicare standards of what would be eligible for hospice. So
Right, it
you
really
get
is not.
rid of that, and hopefully then could be a flow from a serious illness conversation. Ultimately, hospice is appropriate, but it could surely be done in a much earlier stage than you meet this hospice criteria, now we need to get you on hospice.
Yeah. Yeah. You know, in our program development at KU, so we started developing the inpatient palliative care business, you know, about 2003. And at first, the consults that we would get were brink of death consults. I mean, wow. I would be like, oh my goodness, I wish we had more time, you know. So as the service evolved and the whole program evolved, we started moving upstream, you know. And so that we were able to, if somebody wanted to be on hospice, try to get them on hospice before the last 3 days of their life. Now we're working in clinic, and our job is to help them stay on their chemo and radiation as long as that fits for them. And we keep them on their chemo, fewer chemo holiday days because symptoms are better controlled. They don't, you know, if we deal with nausea and dehydration better in the time around their chemo, then they're able to get through their protocol with more support. At the same time we're doing that, we're doing I want this to work. This is the hope for the best plan. But we got to have some safety nets underneath you in case things don't go as we're hoping. But when you're doing that and you still got three different types of chemo regimens you intend to hope they can get, if this one fails, and you're able to build that relationship and iterative process of what that person's hoping for and what their priorities are, it amazes me when we do a good job upstream. You know, now we find that for folks we are seeing in clinic, if they're a medical cancer, a solid tumor patient, if our outpatient palliative care program is following them, the likelihood that they will pass away in the hospital is between 2 and 4%. If we're not following them in the clinic, their likelihood's about 20%. And we follow the bone marrow transplant patients. So these guys are on very aggressive plans of care, you know, and we follow them through high-risk transplant, and we follow them all the way through. And what we hope for is that they get a cure. You know, 15% of allogeneic transplant patients in high risk, you know, will make it beyond 5 years. And I hope and pray for every single one of my patients that they're in that 15%, you know. But if I'm following them all the way along, I will catch the 85% of those patients who won't survive beyond 5 years. And when we have those patients in our outpatient program, the likelihood of them passing away in the hospital is, for BMT, is about 18%. Nationally, it's like 60% in the hospital. So it really does speak to what you're saying about integrating upstream and dropping the idea that somebody has to be in the last 48 hours of life in order for this to become important, right? You know, and I did my hospice training in San Diego at a big hospice there. And that was in 2002. And a lady came in and her husband was at the inpatient hospice unit. And she said something I'll never forget. She said, I don't understand why a person has to be dying in order to finally get the right kind of care. Why are we reserving this for the last 48 hours of life when somebody can benefit from this general approach? Good communication, good teamwork, good pain and symptom management, being able to use a complex, like guiding somebody through a complex healthcare system. You know, it's really basic. It's basic. A lot of this is basic. You know, it's hard, but it's not rocket science, you know. So anyway, I'm sorry, I'm totally off track. Totally got off track. Well, I want to talk a little bit about what we did at KU so that you can see. There's different, yeah.
I have a question, and
Yeah.
this is kind of like backtracking. Okay,
Couldn't hear you repeat the question.
so
Yeah.
I've signed one of these things.
Uh-huh.
Who's the keeper of the form?
Yes. Okay, so that's good. So the question is, if somebody has signed one of these TPOPP forms, who is the keeper of the form? And I'll tell you how we handle it at KU. That pink form is your personal property, and it stays with you as you go home. It stays with you wherever you're at. Now, the trick is when you bring that form in to the hospital with me, say you bring it to the hospital, I have to have a process then for the hospital for me to know, okay, there's a TPOPP form here. I need to make sure it's used, it's reviewed, and used as part of the admission process. You know, then I have to integrate it into my medical record, you know. So what we do at KU is make a copy of that document, and then we scan it into our medical record. And then it's there's a specific process for health information management about what the document type of that is, so it files to the exact same place in the EMR every time. So, and it also tells us it's in there, and we trained health information management to know the most recently signed document is the one that stands, because somebody may have a history of 3 or 4 of these, right? So in the process you build for your institution, HIM, they look at it and they go, is there one in the system already? Yes, no. If there's one already in the system, they compare which one's dated more recently. And if it's old or it's the same as the one already in the system, the copy goes away. You know,
But the pink
if it's,
form always stays with the
the
patient.
pink form always stays with the patient. So if one gets made in the hospital, I also have a process for, I just signed this form, I copy it, I scan it to health information management every time. Boom, boom, boom. I hand the original to the patient with the instruction, it goes home and goes on the refrigerator.
Or at the nursing home.
Or the nursing home.
Copies are legitimate. So even though you're given it, when you leave the hospital, the nursing home or wherever it is you go, the home health agency if they need a copy, the hospice if they need one for their chart, whatever you do, you keep the original and make sure you give them a copy. So everybody should have their copy, and copies are okay. You still follow it. If a new one is issued, yes,
Yes.
Pink
the
form
form
is-
is yours.
Great
And that's the way it currently works. We suggest that you actually take a picture of it and put it on your phone. You need to. I mean, for your loved ones to have, or whatever. It's the same way you would an advanced care planning document. But remembering that it's a physician order, and somebody's going to say, I need a copy of it, and I need to see the physician's signature. So it's both sides. So you need to make sure. But that's the way it works. So it's really, now, if you've got an incapacitated patient, then obviously it becomes the responsibility of the agent or the representative to make sure that it's shared properly with the right people.
So
Okay.
when you review these forms, say that it comes from the nursing home, you scan it, you copy it, it goes to HIM, it goes on the patient's chart, goes back to the patient or their surrogate. What kind of documentation goes along with that?
So the question is, what kind of documentation goes along with the form once it's signed and shared?
So it opens to a really great conversation about what is the conversation that went in the development of the form, you know? And I'll tell you how we do it at KU. But every place is going to have to adapt it to their environment. But if there's a conversation about goals of care, it should be documented in a way that the system can see. You know, it should be documented by the person who had the conversation, you know. That may end up being in a progress note. At KU, one of the tools that we built in our EMR was an advanced care planning note. And so in the EMR, we made a note type called ACP. And if I open up that note type, then up pops a template. Who was there for the conversation? What was the meat of the conversation? Include patient quotes. I love patient quotes. You know, what were the outcomes of the conversation? Did we use other documents? You know, was an advanced directive present? Was a power of attorney present? And so that documentation becomes really important for the other providers to see. You know, I have even signed that, and I write out the content of that conversation and outlining that patient's understanding of their illness and what they would want to see happen, you know, if they were getting a lot sicker. So in our EMR, we built a tool. It's a report that can be accessed through the header where you click on it, and all of the advanced care planning conversations ever documented on the ACP note type come up in that report with the newest one first. So I can go, now we're building histories on some of my patients who've had 5 or 6 conversations, and I can see the evolution of the conversation over time. I can also see that my partner might have had the conversation 2 months ago, you know, and now my job is to see where were we at, what's the new information, you know, and how do I add into that goals of care conversation over time? What do we know about how it's changing? So how each place develops those tools is going to be individual to what type of EMR you have, if you have an EMR, you know, and adapting that. It took us, so a lot of the work that we did at KU was around building the tools we needed for us to be able to be successful. And the ACP note type was an important one that we did. You know, the other thing is that I've even printed them. I had a conversation with a lady, and I said, you know what, I'm going to write all this down. I'm going to print this note. I'm going to bring it in here to you because I want to make sure what I'm documenting reflects what you think. And she also had told me that her family did not agree with her, and she was afraid that her family would not honor the way she was feeling about things. And so I said, okay, I'm gonna write all this down, and I'm gonna make a copy of it, and I'm gonna give it to you. And you can choose if you want to share this note with your family so they know, and it's in my words that you agree with, but whatever, if that helps you communicate with your loved one. And she actually did that. And she found that to be a really helpful thing, and to say, you know, I talked with my doctor about this, and here's what came of it. And that helped her family too, because then they knew what our conversations were, they knew how she felt about it. So a very long answer to your question. I want to talk about a few other things that we did.
I saw some nods over here with your comment about the EMR. Do you guys, who do you have for your EMR provider? Who does your electronic medical? Meditech? And what about Cerner? Anybody?
It's coming.
Okay.
Sorry, yeah.
Cerner is very involved in this creation of this, so it's not an unlikely question for you to call them and say, we need help with us. We want to make sure we do this right. So they're very, very involved in this. Cerner is also, what's the one out of Wisconsin? Epic is also very involved. That's what you guys have, right?
And I know that Wesley's got Meditech, so they've done something with it.
Right. So there are other people out there, and what we've encouraged people to do is to get on the phone, call us, say, you know, who else uses this, and then we'll try to find them for you and connect with them. Because I know with Karin, when you guys were even doing the Epic piece, Karin just said, wait a minute, you know, the answer to what you're giving us as the answer is wrong. I know this can be done, and we can get it, we can make it happen. So there's solutions to that.
Yeah. So I think really, at the end of the day, what's most important is that whatever system we're working in, needs to be able to elicit what the patient's preferences are and then get them into the system in a way that is predictable for all the providers to see it.
And retrievable.
And retrievable, right. And you know, we did a thing with IHI, that's the Institute for Healthcare Improvement, KU did, called Conversation Ready. You can Google Conversation Ready, and it will bring up some cool resources. But to the concept of making somebody's goals of care as obvious in the EMR as the allergies. And that it's really a patient safety issue, you know? We gotta know this. It is as important as the allergies. The EMR needs to reflect these things as well as it reflects the allergies. And trying to make a system build those tools takes a while, but it really it is absolutely transforming how we approach these things now. So to touch on a little bit of what we did with policy work at the very beginning, took a step back and crosswalked the medical staff bylaws, crosswalked policies around how we handle all the types of out-of-hospital DNRs that come. So at KU, we're right on the state line. You know, we can see a purple Missouri out-of-hospital DNR form. That's a legislated form. We can see the Kansas directive, which is an out-of-hospital directive that a patient says, oh, I want to have a DNR order. And then the physician's signature on that document is actually the physician concurring that that is the patient's directive. Makes sense? Different from an out-of-hospital DNR order, right? So TPOPP is an out-of-hospital DNR order. I understand that a very common way that out-of-hospital DNR orders are written across the state of Kansas is on a script pad. However it is that out-of-hospital order is written, the systems have got to have a way of understanding and acknowledging that. So we went through all of our policies to crosswalk those things. And, you know, it may be included in some, it may not in others. So you've got to just know what are the policies in place in your facility. And to know that in order to really be compliant, each place needs to have a policy or wording in a policy that addresses how they will handle a form if it arrives. There's no mandate that everybody do this, not by any stretch of the imagination. But for everybody to know, if they show up on your doorstep, you need to know how to handle it. So we actually have a lot of legal resources at KU, and I worked with our hospital attorney partners extensively on our policies and the wording that's in our medical staff bylaws. And, you know, and I've spoken with our hospital attorney, he said, you know, we've spent a lot of time thinking about this, and we need to be a resource for other institutions who don't have a lot of legal support, you know. So the language that we have in our out-of-hospital DNR policy is available through the toolkit, you know, for folks who are registered. As you're working on your policies, we want to make sure that if you want vetted language, we've got vetted language in those policies to help, you know, help move along. So the other work that we did at KU was really about updating all of our inpatient resuscitation status documentation systems and our orders to make them match TPOPP. And what I found about this idea of how do you talk about these things is I'm like, well, when we have a goals of care conversation with a patient in the hospital or in the clinic, and we're talking about what they're hoping for, how does that translate into a resuscitation status, which everybody has to have when they're in the hospital? If we've done a good conversation around that, when it comes time for that person to go home, then I say, okay, we've talked about this. Do you want these orders to move with you as you're leaving? And if they say yes, I just complete the TPOPP form with them, because it's an outcome of the goals of care conversation we've had while they've been in the hospital, and that we needed to have a valid resuscitation status on the inpatient side. So I recommend that if you want to do this, that has been a successful approach for us. And it also drives then better code status conversations in the hospital, drives education from all different types of provider level, that engages the provider, something they need to do and do better.